Good morning, everybody, and happy Thursday. Can't believe it's already May 11th. So this is the conclusion of the public health emergency as of tonight at midnight. There's a little bit of comfort in knowing that this is our next step forward, but there's also that uncertainty as we navigate through these changes. So we're happy to have you with us today at our quality leader session. We'll be reviewing rehospitalizations. And a few reminders, please let us know what your thoughts are. Feel free to jump in and share with us through the presentation if you have thoughts, or you would like to unmute yourself and be able to talk through any ideas. We definitely want to make sure this is a dialogue and we are sharing best practices and communication as well as our successes that we have going on. Just an overview with one of our last weeks of data coming through at this point. This is looking like South Carolina. We're up to 49% up-to-date status across the state, according to NHSN data, as well as looking at the current COVID spread as of May 7th. So we still have some activity happening out there. We have 40 current COVID cases and a 2.6 COVID rate in our community. So we definitely want to still keep our focus on and working through ongoing prevention strategies, ongoing mitigation strategies to be able to meet the needs of what we see happening in our communities. I pulled the community transition report down, and this is interesting because as of tonight at midnight, this information will not be pulling over to the CDC anymore. So we'll talk a little bit about that. However, as of the 7th, this is what we're seeing for the COVID transmission across South Carolina and various counties. So we still have a few counties that are having high level transmissions in their areas. It's going to be important to ensure that we assess the needs, that we are analyzing our policies and procedures, that we are ensuring that we're providing that support for our residents and our staff to be able to mitigate these potential exposures that we have. And we recognize that there is the option, or what we see out there, of people that have low symptoms, and so they may not be aware that they actually have COVID, and that could be bringing it into our community. So the more that we can just keep aware of what's happening and use our resources and our supports that we have in our communities, that's going to allow us to be able to continue to move forward and provide those services. So I mentioned that with the conclusion of the public health emergency, the CDC announced this week that they will be modifying their data submissions or their data reports. So the community transmission graph is going to conclude because CDC is not going to be capturing that information. We do expect to get more information from either the CDC or CMS, possibly even DHIC coming in the next several weeks. So just keep our ears open for that information, and we'll share that with you as soon as we have it as well. But the updated guidance has been posted on the CDC website to provide information to centers and organizations on how to ensure that we continue with these infection prevention strategies even through the conclusion of the PHE. So COVID is just going to be one of those conditions that's going to be part of what we do and how we provide the care and service for our residents. So the more that we can just ensure that this is part of our operations, the stronger we're going to be going forward. The guidance that's been posted by CDC, there's recommendations for universal source control and defining what universal source control looks like. There's also information about how to do the testing and the tracking of symptoms for residents in nursing homes. So good information to log through. It's just right there on the CDC website. They've also added an appendix to the website to assist facilities with how and when to implement broader use of source control, including examples of potential metrics that are included in there, how we can look at this. Recognizing that community transmission metric will be concluding tonight at midnight, we should be building our relationships and looking at what we have as local information to be able to identify the increasing presence of community respiratory viral activity in our areas. So I think about it on any other disease condition that we may have prevalent in our communities, whether it be influenza, whether we see an increase of norovirus. We have built those systems in place to keep our ear close to the ground to be able to identify when these changes occur. It's going to be the same, leveraging those relationships with our community sources to ensure that we understand what's happening to address and implement those changes. Additionally, the CDC has good strategies in place that's listed in their standards of practice. That includes ensuring our vaccination programs are up to date. We did see recently in the last couple of weeks that the CDC has released information that, and the FDA, that individuals can have another booster of the bivalent booster that was released last fall. They can have another one of those. So work with your pharmacy, your interdisciplinary team, or medical director team to see how that looks like in your organizations. But we should maintain that vaccination program going forward and ensuring that we are providing those services and routinely offering and checking with our families on what they're interested in them. We want to ensure that we have our systems in place for managing suspected or confirmed COVID infections and how we look at the isolation practices and define the different symptomologies. The CDC has a nice summary in this on their website on how we look at isolation practices based on the severity of the COVID infection or symptoms. So it clearly defines what those symptoms look like, which is a really nice opportunity and resource to have. We want to look at how we implement source control measures and how we maintain our infection control standards to ensure we have mitigate the exposure to COVID, but also that we're keeping infection control at the mindset of what we do across the board. As another request that we have before I introduce Julia, this week you would have received an email with 3 questions on it for a short survey about the training and the training sources used to train your staff on COVID and COVID strategies. This CMS has asked us to be able to gather some information on how facilities are doing their training and then what the current compliance rate is. And so it's just the number of staff that have been trained in COVID practices and the total number of staff that you have. It's only 3 basic questions. We would greatly appreciate your support in responding to that survey so that we're able to gather that information for CMS and they can use it in their work to support the conclusion of the PHE, and also verifying that we have really, as a nursing home industry, have really embraced the concept of infection prevention is in what we do in all of our activities, and we maintain that ongoing education and ongoing presence to ensure our staff are fully informed and knowledgeable on these systems and needs. So that help is greatly appreciated, and we look forward to sharing results with you in the future. We're fortunate to have with us today Julia Brooks, who's going to be speaking on rehospitalizations. Julia is a wonderful team member here at CCME with extraordinarily great information, knowledge, and experience within the industry as a director of nursing. And we've had the opportunity to be a part of several of her sessions already. So without further ado, I'd like to introduce Julia to speak on rehospitalization. Thank you, Julia.
Good morning. Can everyone hear me?
Yes.
Yeah. Okay. Good. Good. All right. First thing, I want to wish Happy Nurses Week to everyone. For those of you that are nurses, it will be 46 years next month that I've been a registered nurse, and I've had lots and lots of experiences during those times, as you can guess. 2 that came to mind this morning when I was thinking about this. was that I got to participate in the first CT scan that was performed in the state of Virginia. And that was back in the 70s. That was real exciting. And then around that time frame, I also was a standby nurse for Jimmy Carter. I worked in Newport News, Virginia, and Jimmy Carter was president, and he was visiting Williamsburg, and they had staff on standby. I was in the near local hospital, was a big hospital that was nearest the Williamsburg area. So I had to sit in the break room all night and hope that nothing happened to Jimmy Carter. Since that time, I've had lots and lots of other varied experiences. Some good, some not so good. One that has stuck with me though has been the experience I had in a nursing facility here in South Carolina that centered around rehospitalization. So it's a good story to share with you all today. And it's pertinent to what we're talking about, because we're going to talk more about rehospitalization. So yes, the next slide up is, Chris, I see your comments. Yeah, I was approved to care for him, but luckily nothing happened. I sat in a break room all night. It was kind of funny. So Shonda Rhimes has a new series out on Netflix. And as you probably remember, I've told you I'm partially retired, so I have watched this. Actually, I confess I've watched it twice. Queen Charlotte. And I saw an interview with Shonda Rhimes the other day. I think Willie Geist was the one that had it, and she has since stated it, that this is not a true story. This is a story inspired by fact. So I thought about that today. What I'm about to tell you is a story inspired by fact. It is from quite a few years ago. It is here in South Carolina, and I've lived here about 18 years. But I've had other experiences since. But my time of dealing with rehospitalization in this particular facility really stuck with me. And hopefully I can tell you some points today that will help you because they're still relevant. I was working for a large company, and I was asked to, I was told that I would take another facility in the area adjacent, near to the one that I was currently director of nursing at. The facility in question had a lot of issues. There were very unhappy families, lots of customer service issues, lots of survey and regulatory issues, financial issues. I think directly related to the things I just mentioned was the rehospitalization rate, which was, I think, as I recall, 27%. But I do remember the number 39%. I think at times prior to my arrival there, it had been as high as 39%. But when I was there, it was 27%. Not in that time necessarily a really uncommon percentage. But it was something that was of concern because this facility was near two large hospitals in the area, poised to receive a lot of short-term and acute rehab patients and very complex patients because the hospitals wanted them nearby, such as heart and lung transplant patients, both pre and post. Never did the heart transplant post, but we did do some pre-transplant care for heart patients. And as I said, lung transplants, liver transplants. So some very high acuity going on in this facility that had lots of issues. And it was an older building. So I took that building on, and this was probably in 2008 or 2009. And there was a plan in place for, and something we were beginning to hear about called Interact. And it was connected, of course, to this idea that maybe people didn't need to go back to the hospital as frequently as nursing homes were sending them. And why couldn't nursing homes do more in their facility, within their facility, to keep patients? Well, this intrigued me. I had a hospital background. I had worked in nursing homes by then for I guess about 8 or 9 years, but I still had over half of my career had been in a hospital. And my own belief as a nurse was when they came into my watch or came onto my watch, that it was my responsibility to take care of them until they went on to the next level, whether that be exiting through hospice care or whether that be going home or assisted living, but not to go backwards. That was just my own personal belief as a nurse. And I think that helped me a lot in addressing these issues. But let's see, shortly after I got there, there was a survey. I think 2 days after I got there was a complaint survey and things started that way. However, I really believed, and I believe now, that I could drive a lot of improvement through addressing rehospitalization, and I think ultimately I did. So we'll refer back to some of this, some of my story when we talk about my presentation today. But we did end up, I was only there for about 2 years. It was a challenging building. It was a challenging time. The first year was by far the worst. But in that 1 year period, rehospitalization went from 29% to 3%, which I think still today is almost an unheard of number. There were a couple of factors in that. One was we began taking more and more acute patients. So the larger the number of patients in the pool, that drives down the percentage. So that was definitely a factor. But there were a lot of things we did that nowadays we know better about doing, but at the time we're kind of innovative. One being that we consolidated those acute short-term patients on, well, we started at 1 unit and eventually we had to put them on 2 units because we just had too many. But the 2 units were, one was above the other. They were on the same side of the building. And that's where we consolidated a lot of the resources that were needed for those kinds of patients. And they were also near the rehab area too. So let's go on to the next slide, if you will. Thank you. And I could have done that too, but I need you to fix that little glitch for me. So we're going to fast forward to today. The thing that I want to talk about that I think is still relevant is that we are in a post-COVID, you can go ahead and Alyssa, in our post-COVID environment, we have more experience now, don't we? Monitoring and treating acutely ill residents. And I'll go back and forth between the terms residents and patients. I think of patients as acutely ill folks that are moving on, but they are also residents while they're in a home-like environment, such as a nursing home and a skilled nursing facility. So you'll hear me go back and forth between the terms residents and patients. So we do have more experience because sometimes there was no beds. Lots of times there were no beds and we had to keep these sick people in our setting. So we did gain some skill, I believe, and some experience during that time, taking care of people. Some of the reasons I also think that today we want to avoid sending people back to the hospital and that we're better equipped to do it is it's really the right thing to do. That's a phrase you hear a lot of corporations used to use that phrase. It's the right thing. Do the right thing because it's the right thing to do. And I believe clinically that it is the right thing to do. Today, our focus is going to be on clinical care versus the financial reasons. The financial reasons are important and they're substantial. But if you do the right thing, the financial reasons will come. And we'll talk a little bit more about that towards the end of the presentation. You know, there can be some valid reasons why people need to go out, but some of the things I want you to think about I pulled an old textbook on geriatric nursing and it spoke about 3 nursing goals. The first is to influence health outcomes. The second is to reverse or maintain their health status, depending upon where they are. And the third is to provide comfort care at the end of life. So relative to our geriatric patients, these are the three main nursing goals. So really only, in my mind, only one of these really pertains is relevant to potential for transfers out, because the first one is to influence health outcomes. That doesn't really require transferring out, but that is a goal that we're supposed to strive for with our folks. And we know in South Carolina, it's no secret that lifestyle and not healthcare, but lifestyle is not always what it should be, and frequently not what it should be. So consequently, we have more than our share of negative outcomes. The third goal is to provide comfort care at the end of life. Well, if we've determined that it's truly the end of life and determined the patient's wishes and what their preferences are, we should be able to provide that in our center. There's occasional times when they'll go home or they'll go to a hospice center, but it's not a reason to transfer them back to acute care. There should be ways to manage that. So the second goal that I mentioned was to maintain health status. And that is where sometimes we need to pull out more stops or use more resources than we have in order to maintain their health status. So that can be a goal that we need to sometimes send people out in order to achieve. But I think oftentimes we can even meet that goal in the facility. Some other reasons to avoid transfers out are poor information on the transfers, poor information exchange on the transfers to and from the facilities. And that's in both directions, especially related though to the baseline physical and cognitive function of the patient. And often we know in the nursing homes, we are the experts in that. We think about that more. We have more time with them. We've had a longer time with them in many cases, not always with rehospitalization, but most of the time, even then, we could have had a few weeks with them. Also, another reason that to avoid rehospitalization is unclarified predetermined wishes and what is their code status. If that's unclear or they're still deciding, that gets even further muddied by the transfers back and forth between facilities. Also, vague, undocumented signs and symptoms that prompt the transfer. That starts to get very confusing for the caregivers on the receiving end if we send people out for various reasons because, you know, they're difficult or for whatever reason, not desirable to care for. And we know sometimes that happens. That can prompt the transfer, but it gets very confusing to the hospitals to try and figure out what's wrong with the person and can result in some unnecessary testing. And I'll mention this again later, but e-charting, I think, helps a lot. Being able to review e-charting from a central source from your computers really helps with the documentation oversight. And I think that's very, very important. That is not something I had, by the way, when I was managing rehospitalizations at the center I mentioned to previously. And if things aren't clear, the treatment isn't clear, and the patient may decline further or may not improve or may have events or things done to them that really aren't necessary. An example is I have I call it my bum knee. I have a bad knee. In August, I saw a new orthopedic surgeon and he prescribed a new medication, one of the filler gel shots that worked really, really, really well. Knee did well. 6 months later, knee's not doing well. I returned to the doctor expecting to get the shot and be able to run marathons or whatever I want to do for another 6 months. And no, I don't run marathons. But went back to the doctor last week expecting the shot, told him what had been going on. And he said, I can't do your shot. I think that you might have something else going on, because the symptoms you've shared with me are not the same symptoms that you talked about when I saw you in August. So long story short, had to have an MRI, eventually did get the shot. But there was some confusion, and the symptoms that I was reporting and thinking about myself were kind of vague until I got into the office and my nursing reporting skills kicked in, and I told him in detail what was going on, and he needed to do some more research. So long story short, I did get the shot, but I'm probably facing another arthroscopic surgery. Total knee is not in the cards for me yet. I'm probably one of the few patients that's really anxious to have a total knee. But anyway, vague, undocumented signs and symptoms can throw off the treatment, can delay the treatment, and can cause unnecessary testing. So we want to avoid that in our centers. Also, when they go to the hospital and now they return, so say they've been in the hospital, they've come to us. We know what can happen. We all have systems in place for checking and reviewing orders and so forth. Meds can get dropped, meds can get added, old meds can be put back in, that kind of thing. So now they've gone back to the hospital, and we maybe haven't communicated the best ourselves, or we have those vague signs and symptoms that I referred to. Now they're returning to the nursing home, to our centers from the hospital. And what kind of risk can people encounter from that? Well, the one that used to break my heart, was the loss of function that people experienced. I've had some physical therapists tell me it's no longer considered really the standard, but I do believe that it's still a factor, that when, for every day that someone over the age of 60 lays in bed immobile, they lose a week's worth of their ability. It's going to take a week to gain back what they lost in that day. So if they're in the hospital for 7 days, immobile in the bed, that's 7 weeks of therapy just to get them back to where they were when we sent them to the hospital. So that's a big loss of time. And, people of a certain age don't have a lot of time. So time is important to them. Time is important to us. So that loss of function that we've had happen because we've sent them back to the hospital is difficult. So physically, they have to start all over. The other thing that I think people have seen frequently, and I used to see too, is they come from the hospital, then they're in fluid overload. And so they've gotten into CHF. And so this is a new thing. Maybe cardiac was not one of the problems that they had before, but now they have CHF, either as a result of fluid overload or aggressive rapid rehydration. Because we know sometimes they're on the cusp of dehydration when they're with us. And the hospitals make that assumption too. So they overload them. So now we've got a new problem to deal with that was not necessary. The next thing is the indwelling catheters, specifically mentioned in an article I read was indwelling catheters, but they come back with all kinds of lines sometimes and things that have been overlooked. And then the last risk that we have when they return to us from the hospital is our discovery of nosocomial infections upon return. Even COVID was something that I know frequently was discovered. They'd gone out to the hospital. I did site visits with several buildings that recounted that patients had gone out to the hospital, and then when they returned, they had COVID, even though the hospital said they were negative. And sometimes this started outbreaks. So something else to think about, whether it's COVID or another nosocomial infection. So all reasons and risks to try and avoid that transfer back and forth in the first place. Something I do want to talk about, let's see, for a minute, and this is a good point to talk about it, is also consider the burden of treatment required to extend life. a good quality phrase that we hear often and use often, and I used to abide by, was risk versus benefits. But think about this in terms of risk versus benefits. The burden of treatment required to extend life. Could meds or minimal invasive surgery or non-invasive testing be used from the facility location instead of sending people back and forth? So look at your patient's overall condition, look at their preferences, and recognize what's likely to happen when they return to the hospital, and consider and discuss the burden of treatment required to extend life. I thought that was a good phrase and a good thing to put in the forefront of our minds when we're evaluating and thinking about rehospitalizations. Next slide. So we're going to begin. How do we begin? We're post-COVID now, as I said. Where are we? What do we need to do? Well, the first thing I would suggest is look at 6 months or so worth of data. And don't forget to include all of your population, not just the ones that count in your measures. Include all of your population, because the long-term people, a lot of times when I looked at my long-term people going out, the things that I found were little things like not enough lab supplies, or we weren't calibrating blood glucose monitors often enough, or something like that, that applied to everybody. So your long-term people will often help you show that up too. So begin with your debriefs and your interviews. For every transfer out, as I said, long-term or short-term, new or old, every transfer out. Share and post your current data as you're collecting it. You'll begin collecting data. You know what's your rehospitalization rate. Begin to share and post that, just like you did your COVID rates and your county rates. So you've gotten in the habit of doing that. This is something that you should easily be able to do. Get yourself on the floor to give yourself access to staff so that they can involve themselves. You can be involved and they can ask questions of you. Assess patients yourself. There is nothing wrong with that. You'll learn, you'll keep your skills sharp as a director of nursing or as a nurse leader, and your staff will learn from you too, and your patients will appreciate it. Some other things you can do as you begin is contact the ERs that are the recipients, likely recipients of your transfers out, and visit them in person if you possibly can. Identify yourself and get to know the leadership in the ERs. And make sure that you know how to contact them, because they're changing staff over almost like we are. So you want to make that connection, because you're going to call them and get information and feedback from them after you send people out. And you'll be surprised the net results of that. When I did that, I developed good relationships with 2 emergency rooms that were nearby, and they actually would loan me resources sometimes if we were short on things. They offered to do some education. I invited the emergency room staff to come and tour the nursing home, and that was quite an experience. We gave them lunch and did all kinds of things and took them on the tour through the building, and they left with quite a different attitude of what nursing homes can do and do. So that was a good event. The biggest thing is, go ahead and next slide. The biggest things are to be objective. That's what the left slide is supposed to mean, and go deep. Really, I think sometimes we think that the best care is to send someone out, and that's not always the case. In fact, I'm going to say that it's seldom the case. So be objective in your findings, be honest with yourself and the people you report to about your findings, and go deep. These interviews, I mentioned the emergency room. Some of the other people you want to interview are the families, the patients themselves, if you can. They appreciate that people want feedback from them. So if they're able to give it to you, contact the patients, contact the families, ask them what's going on. We also know from our experience that there are times when people and families want to transfer someone out, and it has nothing to do with a real change in medical condition. It can be uncontrolled pain. It can be, lack of confidence in the nursing center. There can be all kinds of reasons that have nothing to do with a true medical change in condition that people want to go out for. And if you do these interviews, you'll begin to establish that. The interviewing has dual purposes as well. Not only do you gain information, you'll gain attention and focus from the people that you interview, because you're showing that this is serious enough for you to give your time and attention to it. Don't forget your transferring providers, your medical providers. A lot of times the medical directors have nurse practitioners and PAs that work for them, and they are on call, and you really need to track that data. Who's sending people out? Is there a higher percentage through a certain vendor? Talk to your vendors, to your providers, excuse me, every time, and ask them why, what went on. And some of it's their comfort level. Some of it is lack of communication. Some of it's legitimate, but talk to them every single time. And you're thinking to yourselves, if you're a director of nursing, well, I don't possibly have time for that. I have people going out once or twice a day. If you decide to commit and invest in this, and you really need to, you will quickly begin to get results. You will quickly begin to get some positive results. And we're going to move right on into that with the next slide, talking about planning and implementing. There are several things. I think you can keep clicking, Alyssa. I think, yeah. So share your findings. You've begun to do some data collection. You've done some chart review for the last 6 months. You've looked at your data and your statistics, and now you're doing interviews with staff, the transferring providers. You're seeking feedback from residents and families in the emergency room. So you begin to get quite a bit of data. So share your findings, share them with the administrator and the medical director on a regular basis. I made a mistake of trying to convince my medical director right away with the findings that I had at this particular building I mentioned, that we needed to make some changes. He was not quite as quickly on board, shall I say. And what I would do now is simply share the findings and not my conclusions or my opinions quite so quickly. And he might have come around sooner, but we'll talk a little bit more about that in a minute. And we want to share that with staff. There's where you can also share some more detail at staff meetings and in huddles and during conversations on the unit about what you're finding and what you're seeing, and ask about that. Seek validation for that. Staff that want quality care and genuinely care about their residents will tell you what's really going on, because sometimes what you think is going on is not really what's going on. I had a situation, this is a good time to tell you this, where while I was consulting, there was a building with a very high number of people going out, pretty good building with pretty good care, and couldn't figure it out. So I started having small group meetings and one-on-one meetings. And when I got down to the one-on-one meetings, the CNAs told me that they didn't like the nurses, didn't trust the nurses, and they were often advising the families to demand that the residents or patients be sent back to the hospital. So don't think it doesn't happen, it does. So something to think about. Begin sharing your findings, seek that feedback. They'll open up and you'll be surprised what they tell you. I think we have some more here, Alyssa. 2 tools. I mentioned planning and implementation. This is a fairly critical environment that we're talking about, and fairly critical process. So I'm talking about planning and implementation as one. That's not a typical quality standard, and I know that, but we don't have a lot of resources in nursing homes, and we have to move fairly quickly with this because it's pretty much out of control. So I'm mentioning planning and implementation in one package. 2 tools that I suggest you consider right away are the Stop and Watch from Interact. That was the very first thing I did at this building that we talked about, was I put Stop and Watch in place. That was really, there were some other things coming from Interact, but that was one of the very, very first things. I tried to determine that yesterday, and I can't confirm that 100%, but Stop and Watch has been around for a long time. It's fairly easy to implement, and it gives you a lot of good feedback. And then the Decision Guide, which is one of the newer tools from Interact, and one that we have a program about, is also a very good tool that you want to think about using, because that brings your family and resident into the decision making from the get-go, which is really important. We talked about that. You don't want, indecision and indecisiveness around this end of life and so forth. You want decisive information. So the Decision Guide can really help with that. So think about too, you'll begin to see commonalities emerge, and you'll begin to see, as you talk to people and gather all this data, you'll begin to see things. I would suggest that you not put more than 1 or 2 tools or forms in place at a time. Interact is a big one. Interact was my favorite and still is, but there are software programs out there. There are all kinds of other tools that you can use. Share these results, share them with your medical director, with your administrator, and your staff, and the families and residents, and circle back. Keep looking, because you're gathering more data and you're planning and implementing at the same time. So circling back and evaluating what you're doing is really important. But I wouldn't put more than 1 or 2 tools and forms in place at a time, because what you're really talking about is a culture change. And you can throw a lot of forms and tools at people and feel like you've addressed the problem, but you may not solve the problem. And once you solve the problem of hospital returns, you're going to be surprised how much else will fall into place for you. I know I was. Another thing to think about as you're planning and implementing is, I would suggest that you build your policies and procedures around the transfer process. In other words, things you feel you need to address. One example is and this was true in the building I was in, and I've seen it since, the Falls program basically says if they hit their head, send them out. If they're bleeding from their head, send them out. Well, certainly if they're bleeding from an ear, but if they have a scalp wound, they're going to bleed. That doesn't mean that they've got an inside head injury that needs critical care. So make sure that your policies make sense, and consider building your policies around the transfer process, but certainly include any regulatory compliance that you need to include. We tend to do it the other way around. We build our policies and procedures around regulatory compliance, understandably, and sometimes following these policies and procedures unnecessarily results in transfers out. So just be careful about that. One thing that helped me with this building I was telling you about is I kind of got real curious about all this and why people were going out and what people thought and what did we need. And it was a vehicle, if you will, for me to get to know that building that was new to me, relatively new. So be curious, be genuinely curious about what's going on. And you're going to get some answers, and they're probably answers that you didn't expect, like staff is actually advising families to send people out. So, and these are things you need to know about. So be curious and listen carefully, because you will find out some interesting things. Okay, next slide. Okay. Now, right away, we've just started planning and implementing, and I'm telling you to celebrate. Find that small success. If you were able to keep someone, say you did vitals on someone every hour overnight, and eventually they declined more. Maybe you gave them fluids or whatever, but eventually there was something you couldn't quite figure out and the doctors were concerned about. And this was a patient who was to go home after short-term rehab. So again, you weigh your risk versus benefits. And this person ends up going to the hospital, but maybe they stayed with you an extra 24 or 36 hours and were able to have a couple more sessions of rehab, which made them progress a little bit. That's a reason to celebrate. If you sent them out with good information and they were able to return to you quickly, they didn't lose all that function that they lost before. Remember, a week's worth of therapy for every day that they're immobile. Maybe they were only there 3 days, which is 3 weeks long, could be 3 weeks longer with you, but that's still progress. So look for small steps, small successes. Be loud. You know how to celebrate success. Be loud about it, be timely with it, and look for the small successes. Be thankful to that night shift who did vital signs all night long to get someone's blood pressure under control. Praise them for that, because that can be a lot, but they only had to do it for one night, and they will be your strong, good nurses will be pleased. I can't tell you how many times, especially with my night shift in this building, that I would praise them for something like that. And I saw them really evolve from older nurses counting the days to retirement to involved, engaged nurses who began calling me at night with things, changes they were seeing in their patients. What should they do? That kind of thing. So I saw a big change. I can think of one nurse in particular that really changed a lot through the rehospitalization process. So look for those small successes, look for them early, because they will be there, and be loud in public and praise often. Those are all standards that we all should do as leaders anyway. Next is, wait a minute, excuse me. Share your successes. Who are you going to share them with? You're going to share them with all the people we talked about before that you received data from. You're going to share them with your medical director, your families, let them know that's a priority. Your patients, that we want to keep you here, keep you safe, and not bounce you back and forth in that old ambulance. And consider exchanging best practices. Changing best practices will net you more ideas. You will share your best practices, and you will hear best practices with other facilities, other directors of nursing in your company. And you'll get new ideas just from what they're telling you, which I think is really cool. Your outcomes will surprise you. Staff morale will improve a lot. Just your daily shift operations will begin to get better. And I used to wonder about that. I saw, families were happier, families were more confident. Of course, the administrators and the regionals were happy because money was flowing better, especially as time has gone on and it's become even more significant. The nursing staff, not only was morale better, but they were a lot more confident. And we had smoother shift operations. because even that one person that you have to address and pack up and send out, and maybe at the same time someone's coming back in from having been sent out a few days before, is actually very disruptive. So if you think about it, you don't think about it while you're in that mode and in that culture, but once you get out of it and you get down to a 3% rehospitalization rate, things just run so much smoother. And it's sort of exponential as we got down to about, well, below 20%, we saw a difference. Below 15%, things were getting better and morale was definitely improving, and people were on board and saw that this was a potential and a possibility, and that there was a better way to care for people. And by the time we got to 10%, of course, we were all just ecstatic, and we didn't make a lot of changes that I can recall after going to about 10%, because it just exponentially gradually got better and better. The nurses' skill sets were getting better, so they were happier. Overall morale was better. Their skill sets were better. And one of the ways those skill sets got better was I had emergency rooms offering to do some training for us on various things that they saw that maybe we could have done better on. So we had better training. We had closer oversight. MD was on board, willing to try things. There was more collaboration between the nurses and the MD. And all of this happened within about 12 months. Because the reputation got better, the surveys were better. The customer satisfaction surveys were much better. Regulatory wise, there was not as much question. And I think we did better regulatory wise. Documentation improved a lot. It was right after that 1-year mark that we began doing electronic charting in that building. So really we accomplished this without electronic charting, but documentation is a big factor in survey compliance and survey tags. So our documentation got so much better. And then of course it continued to improve with electronic charting, because it's much easier to have oversight of electronic charting. Okay. So some of the rewards, I mentioned a lot of the outcomes, but some of the rewards are the pride of the staff and the leaders, as well as the community. The financial rewards. Obviously, I was able to increase some staffing as our acuity went up. And it was interesting, the higher our acuity went, the better our rehospitalization outcomes were, which seems like it wouldn't be the case, but it was. But I think we acquired that higher acuity because people were gaining more confidence in us. But of course, as that happened, we had higher acuity, the finances got better. There was more bonuses and benefits for staff. There was more equipment. We were able to get, and I don't necessarily recommend this, but we did have an EKG machine that an ER gave us, and we did learn to use it. We didn't use it often enough to really benefit us, but we did get more equipment. Things were top notch. Life was just better in general, to tell you the truth. And we got improved applicant flow. Nurses from the hospitals, who had avoided nursing homes, but maybe for one reason or another wanted to change. I was able to attract med-surg nurses with a med-surg background who were willing to try and take on more patients in the nursing home because they had a much larger number to care for, but they knew that they were able to do it, and our systems and resources and processes were strong. So that was another positive thing. And as I said before, the shifts ran smoother, and the operating systems in general just ran smoother. So all these things were really, they just exponentially, kind of one led to the other. There were, as I said again, I'll say one last time, there's a lot fewer disruptions. You don't realize how disruptive that transfer process is. I think in the back of everybody's mind, that's one less person on my shift. But if you do the transfer properly, and even if you do it improperly, it's still very disruptive on a lot of levels. There's a lot of phone calling, a lot of documentation, a lot of physical work to get the person ready, a lot of waiting. And it's just nice to not even have that be part of the equation anymore for everybody, especially, number one, the patients and residents who don't have to be herded into an ambulance in the middle of the night. So I can't really think of anything else specific. I was trying to think of some other examples from that particular facility. I did mention the medical director. I did have to go in a few times on Sundays. Usually it was during a football game that I had to, he would call me and say, the nurses called me about XYZ. Would you please go and look at this patient? So I drove the 20 miles several times and went and actually looked at the patients. Is that something that and 2 out of 3 times, I did it 3 that I can recall. 2 out of 3 times the patient was able to stay in the facility, and the doctor's reliance upon us really kept increasing. I did not want to do that for a long period of time. There are enough reasons why DONs get called in on off hours. I had to do it quite a bit at first, got calls at night. The medical director knew he could call me anytime. He did have me go in. For some reason, it was Sunday afternoons. He asked me to go in, and he said his option was to send the patient out. And I said, no, I would go in. So you have to invest and commit upfront as a director of nursing. And it really needs to come from you as the head. Unit managers can be, they need to be on board with you. But as you're really trying to get a rehospitalization process and program started, it's really important that you be the one to lead it as a DON. So that's all I have. Any questions or comments?
Julia, thank you so much for the information. There were so many things I was writing down as you were talking, and just the idea of getting with the hospital and having the ER staff or representation come to the building and tour the building. What an amazing opportunity to really firm those relationships up and build that continuum of support.
It made a big difference. And that particular emergency room, I believed, had called in several complaints. And I know from being a patient in an emergency room on several occasions, as nurses, we're aware of our surroundings no matter what, and hearing the things that are said around nursing home transfers and about nursing home transfers. I felt like that was pretty significant in that one ER in particular, and that all stopped. I can't guarantee those things were coming out of that ER, but I was sure of it later because they stopped. Once we invited them, I visited them, and they had a fair amount of turnover, but I did stay in touch with the ER director and the medical director of the ER on they had my number. I was in that building for several years, so they knew to call me, and they would call me first, either about things like skin breakdown that maybe we hadn't reported. Maybe we knew about it, but there was some oversight and we didn't report it through that process we talked about. But they would call me first and we could address it. So yeah, and then having them come and tour was just amazing. It was amazing.
It's a wonderful idea. Anybody else, if you'd like to unmute yourself, or you can type in the chat box. We're down a little bit longer and able to talk these ideas through further. We're giving some time. Definitely want to do a promotion for some upcoming events we have. We're very fortunate. Next week we have DHIC next session on the 25th. DHIC will be presenting on antibiotic stewardship, getting back to our basics on how we run facilities and do operations. On June 8th, we have a presentation from Simple LTC, or the Easy PBJ company. They're coming in to talk about understanding staff metrics with the star ratings. You may recall that as of July last year, the star rating metrics were updated for Care Compare. They're a little bit more complicated than they've been before, so this is a good opportunity to understand how they're all rolling together and what this looks like from a overall understanding on STARS. On July 13th, the South Carolina Coalition for the Seriously Ill will be presenting on advanced care planning and the POST tool in South Carolina. Another great opportunity to get back to the basics and how we're looking at operations and supporting our residents. And then a special CEU event, free CEs for our participants. Evelyn Cook of SPICE will be presenting on infection prevention protocols, elements for performance. This is a great opportunity as we get ready to go into flu season. I shudder to think that August, we're looking at that, but back into flu season and getting prepared for that. And on August 24th, our own Beth Herscher will be presenting on the Leadership Academy and the recruitment for our next phase. So if you're interested in looking at or being a part of staffing, workforce development and staffing resiliency, Beth Herscher's work has been really interesting and enlightening, and I think that there's some great opportunities, and she's recruiting 40 additional buildings in South Carolina that want to continue that work. Okay, I'd like to ask if there's any additional questions that anybody has. Not seeing any. I want to thank you for joining us today. A big thank you to Julia Brooks for a wonderful session. Thought-provoking as always. I have my notes all written down of things that I'm interested in. Thank you so much for that. And we wish you have a fantastic day. We'll see you all on May 25th.